Good afternoon. Welcome to our medical update webinar series called The Intersection Between Tuberculosis and Mental Health. So the learning objectives for the webinar are what you see on your screen, that you will be better able to understand the complex relationship between tuberculosis and mental health, assess the mental health status of TB patients in order to determine appropriate interventions, and develop strategies to manage psychiatric complications in TB patients in order to improve overall treatment outcomes. Our faculty today are Dr. Ami Petrawala, the Medical Director of the Global Tuberculosis Institute and Assistant Professor of Medicine at Rutgers, New Jersey Medical School. Dr. Annika Sweetland, Global Mental Health Research Fellow in the Department of Psychiatry at Columbia University College of Physicians and Surgeons, and co-founder and co-chair of the TB and Mental Health Working Group at the International Union Against Tuberculosis and Lung Disease. And finally, Dr. Adam Karpati, Senior Vice President of Public Health Impact at the International Union Against Tuberculosis and Lung Disease. Our agenda for today are to provide an overview of TB and mental health. This will be done by Dr. Karpati and Dr. Sweetland. Have some case discussions, which will be done by Dr. Ami Petrawala. And then finally, we'll have some time for questions and discussion at the end.
Hi, this is Ami Petrawala. Welcome. So our two speakers today I'm pleased to welcome are Dr. Adam Karpati and Dr. Annika Sweetland. Dr. Sweetland has a clinical background in social work and is co-founder and co-chair of the TB and Mental Health Working Group at the Union. She has previously worked with Partners in Health to facilitate psychosocial support for patients with multi-drug-resistant TB in Lima, Peru, and her interest is in international mental health, including cross-cultural implications and translating research into practice. Dr. Sweetland received her Master's of Social Welfare from the University of California at Berkeley School of Social Welfare and her doctorate at Columbia University Mailman School of Public Health. She is currently a postdoctoral research fellow in global mental health at the National Institute of Mental Health and at Columbia University. She has 3 ongoing research studies in Brazil exploring the prevalence of depression among homeless individuals with TB, methods for integration of TB and depression treatment in primary care at a systems level, and exploring inflammatory biomarkers for depression in the context of active and latent TB infection. Dr. Karpati oversees programs designed to strengthen public health systems and address leading causes of morbidity and mortality in low and middle income countries. Prior to joining the Union, Dr. Karpati worked for 14 years at the New York City Department of Health and Mental Hygiene. His tenure included serving as Executive Deputy Commissioner for the Division of Mental Hygiene, responsible for programs, policy, and epidemiology around mental illness, substance abuse, and developmental disabilities. Dr. Karpati obtained his medical degree from McGill University in Montreal and completed a residency in internal medicine at New York University Medical Center. He then served in the Epidemic Intelligence Service at the Centers for Disease Control in Atlanta and completed CDC's Preventive Medicine residency. He also has a Master's of Public Health from the Harvard School of Public Health. And I'll turn the program over to Annika and Adam.
Adam and I are going to sort of speak, our slides are intertwined, so I'm going to lead and then Adam's going to join in for a few points during the presentation. I'm going to begin with a brief introduction, an overview of mental health issues, looking at TB and mental health specifically, what's the impact on treatment outcomes, what are some of the types and causes of mental health problems that emerge in the context of TB, and the epidemiology and frequency of these types of problems. Then I'm going to address some challenges and responses, and finally some conclusions. So to begin, why are we talking about this? What we know is people with mental illness and substance use disorders are more likely to be exposed to TB, which in large part has to do with exposure in institutional settings. They're more likely to develop active TB, which often has to do with inflammatory processes or health risk behaviors. They're more likely to delay seeking care, more likely to miss doses once in treatment, and more likely to default from treatment. And as a consequence, they have a greater risk for having more advanced disease once they do present for care, more likely to develop drug resistance due to inconsistent treatment, more likely to fail treatment and die, and more likely to be infectious for prolonged periods and therefore posing a risk for community transmission. So I'm going to go into each of these in a little bit more detail, but that's just to give an overview. We also know from other medical disorders that treating mental illnesses can improve medication adherence, treatment completion, and cure rates, which would have the impact, in this case for TB, reducing drug resistance, reducing community transmission, and reducing mortality, improving cure rates. So when we talk about mental health, what are we talking about? Mental health versus mental illness. A range of emotions. There's a range of normative human emotions that are normative. For example, depression and sadness, anxiety, fear are all part of the normal human experience. So what's the difference about when it becomes a disorder? If we think about an example of an individual who's very sad, tearful, hopeless, and you find out that the person just lost a loved one the day before, then it makes sense that the person would feel that way. That the reactions are the depressive hopelessness and tearfulness may be even extreme and disabling, but it's short term and it's proportional to a very specific stressor, and it is in fact a normal reaction to that stressor. If you were to find a person presenting similarly and learn that it was actually that their partner died, say, 2 years ago, and this is still their current state, that suggests a pathological process that it's no longer tied to the specific stressor. It's significantly impairing. It may be affecting a person's ability to relate to others or to work. The duration is long beyond what it quote unquote should be. The severity is not, it's not relenting, and this is suggestive of a more clinical underlying disorder as opposed to a normative reaction. Another example would be, finding yourself in the middle of the woods with a wild animal and feeling afraid and anxious and nervous. All of these, of course, are normal reactions, even adaptive responses that would allow you to, the fight or flight response. However, if you're continuing to have that reaction, and if the wild animal is something like a mouse, then it sort of changes the context and the scale of what the stressor is, what the reaction is, how disabling it is. So that would be an example of a phobia. And so that's just to give a very cursory difference between what is sort of normal mental emotions and behaviors to when it comes into a different category of disorder, which then requires a different type of intervention and treatment. The most common types of mental disorders include mood disorders, such as depression or bipolar disorder, previously known as manic depression, anxiety disorders and phobias, non-affective or psychotic disorders, such as schizophrenia, PTSD or other trauma-related disorders, and substance use disorders. And notably, psychosis as a symptom can be present in any one of those disorders. Adam wanted to say a few words about terminology and about the U.S. health system.
There's a lot of confusion when speaking about mental health and mental illness. I think, as Annika just described, we have some ways of distinguishing clinical syndromes from less significant experiences. I just wanted to say that we often use some of these terms interchangeably, mental health, mental illness, and I think mental illness is a much more descriptive term. There's a lot of different words that we use to describe substance use disorders or substance abuse. I've listed some of them here, and I think there's also this important to think about severity and to think about impact. So substance use can refer to a behavior or a practice. Substance dependence, for example, is a much more clinical syndrome, and substance use disorders is probably the most specific of all. A word about serious mental illness and what people might refer to severe and persistent mental illness. These are meant to denote situations where clinical mental illness is more serious and more impairing and more disabling. The term severe and persistent mental illness is typically used to describe individuals who may have had experiences in a long-term institutional care or have clinical syndromes consistent with having that experience. There's different terminologies for people suffering from mental disorders, and I've listed some of them here. And we're talking in this presentation mostly about mental illnesses such as depression and anxiety. We're also speaking to some degree about substance use disorders. Often these are grouped under the term behavioral health. Mental hygiene is another term that's often used. So I'm not saying this to point out what should be normative or what the right terminology is, but really just to highlight some of the ways we talk about this. And I think it's important for to be as specific as possible when discussing these issues.
Oh, sorry. I thought this was the other slide. So what are some of the causes of mental health disorders? One is genetic predisposition. In particular, with relation to, let's say, depression, schizophrenia, there's a large hereditary element. What that means is not that just because someone's parent has schizophrenia that they're going to definitely get it. What it means is that there's some amplified risk for that person, and if they, during their course of their life, have some triggering events, which tend to be sort of trauma experiences, they would have more likely than the average person to develop schizophrenia or depression in that context. So it's a hereditary risk, but it's not prescriptive. Other causes of mental illness are exposure to trauma, violence, abuse, family disruption, psychosocial triggers such as immigration status, job loss, and medical comorbidities, which gets into more of what we're going to talk about today. Depression in particular is highly comorbid with a lot of medical illnesses, and I just pulled up 4 systematic review and meta-analyses that found the prevalence of depression among people with HIV, cancer, chronic obstructive pulmonary disease, and diabetes to be very high, ranging from 0 to 49% in some of these cases. And this is important because depression is associated, or depression and other medical illnesses are associated with poor medical outcomes, as we discussed before. So in this case, for example, depression and anxiety are associated with 3 times greater risk of non-adherence to medical treatment. And this is for a range of medical conditions. It's associated with lower quality of medical care and premature deaths across the board. In fact, it's estimated by the WHO that people with serious mental disorders die an average of 10 to 15 years earlier than healthy individuals. And they don't die from schizophrenia or depression. They die from not taking their treatment, for not going for care for other physical conditions, infectious disease, suicidal behavior, and all of these secondary health risk behaviors, etc. So, so now Adam's going to talk about the U.S. health system.
So I think part of the theme here today is to try to talk about bridging what are often very separate systems, the medical and the mental health systems. In the United States, mental health is often typically regulated and reimbursed separately from the medical system. In many state agencies, for example, physical health and behavioral health are administered by separate agencies and reimbursed separately. Managed care models are often distinct as well, where there may be different insurance systems, different payment models for behavioral health and for physical health. At the federal level, this is replicated. Behavioral health issues have one federal agency dedicated just for that. increasingly in the United States, the Medicaid system is particularly influential in driving the system of care for mental illnesses and substance use disorders. And this is interesting because typically the state agencies that oversee and regulate the system are distinct, as I said, from the Medicaid system, which is often associated with health departments, with state health departments. Another feature of the mental health system in the United States is that it's characterized by a wide variety of clinical practitioners, from psychiatrists, physicians, psychologists, social workers, nurse practitioners, etc. So there's a wider variety of practitioners than typically seen in the medical system. And the last thing I wanted to say about the system in the United States is that the mental health system, in some ways, has a long history of acknowledging and building in attention to social factors for integrating community-based rehabilitation and social services for people with serious mental illnesses, and really practicing a sort of holistic, so-called recovery approach to mental health. And I think that there are areas on the medical side, on the physical health side, that do this as well. And I think TB care is one of them. And I think that these are principles that are needed to really combine and to bridge the two systems that we're talking about today. This is just a slide to indicate to show some information about the treatment gap for mental disorders in the United States. This is a national representative survey called the National Comorbidity Survey from the early 2000s. This was an interview-based survey, nationally representative, and these are the proportions of people who had a diagnosable mental disorder, at least according to this was a pretty rigorous survey, so according to the very rigorous techniques that were employed in the survey to make diagnoses, and the percent of the respondents receiving care for their condition. And you see that if you go to the right of the slide, any sector, that only 4 in 10 people suffering from a mental disorder were receiving care. The most common setting was in general medical provider, only about 12% by psychiatrists, 16% by other mental health specialists. So this is the data that is often used to talk about how most mental health care is actually provided in general medical settings, and also to make the point that most people with mental disorders are not, in fact, being treated for their conditions.
Okay, so now when we start to talk more specifically about TB and mental health, what we know so far, there have been 3 review studies in the last few years. One that looked at TB and depression exclusively, one looked at TB and depression anxiety, and one looked at any mental disorder associated with TB. And they all found very high prevalence, from 11 to 80%, looking at all the 3 studies. And I can speak to the first study, which I was involved in, the top one, that this is likely to be, as a caveat, likely to be an overestimate for a number of reasons. Most of the scales, most of the countries, it was 12 countries, 33 studies, and most of the studies use screening scales, like tend to overestimate, and the quality of studies was variable, but this is definitely suggestive of a very high rate, and the fact that the other 2 studies also found extremely high rates suggests that this is something that we need to pay attention to, particularly as it relates to the negative outcomes, which I'm going to discuss in our next slide. But also, as a final note, TB and HIV co-infection amplifies risk for depression by 1.7%, 1.7 times higher risk of depression. And so from the TB literature, we find is that alcoholism is associated with treatment delays, that mental disorders are a risk factor for higher drug resistance, that substance abuse in patients with MDR-TB is associated with treatment default, that alcoholism has 1.6 times greater risk of death, and mental disorders have 1.8 times higher risk of death with general TB, and this was from a large, over 300,000 population study in Brazil, and that for MDR-TB, having any psychiatric condition is associated with higher risk of death as well. When talking about the TB in the U.S., it's a little bit different than in other countries. We know that it's about 65% foreign-born, although that rate can vary across the country. For example, in New York City, it's probably closer to 80% foreign-born. And there is some research that suggests that foreign-born individuals have lower rates of substance abuse, although there's no way of knowing if that's linked to this particular population. About 6% are homeless, 4% incarcerated, 7% HIV positive. And although we don't have specific statistics about what proportion of people with TB in the U.S. have severe mental illness, we can presume that it's relatively high, or that higher than the general population, given these other shared risk factors. So there are 5 basic types of mental health problems that can come up in the context of TB. First is the psychological reaction to the diagnosis or treatment. Second, psychiatric side effects associated with TB medications. Third, physiological consequence of the disease itself. 4, exacerbation or emergence of mental health issues, so either retriggering or relapse or new onset of mental health issues based on the stressor. And finally, comorbidity as a result of shared risk factors. So in terms of the psychological reaction to the diagnosis, one of the mechanisms which this happens, particularly in a lot of other countries, I think that there's less social stigma in the U.S., I think, than in other countries, but the social stigma can manifest in 2 ways, externally and internally. Externally, people with TB can be rejected or be blamed, or discriminated against because of the social stigma. The flip side is if they have internalized these stigma beliefs, they may direct those feelings inwards in terms of feelings of shame and guilt. They may withdraw socially or isolate themselves. They may have feelings of depression. Functional impairment that's related either to the disease or the treatment itself can be psychological stressor. The risk of infectiousness or exposure in households can be a stressor. And as I was just discussing this, TB tends to impact very vulnerable populations in the general sense. So people living in poverty, in which case this can be exacerbating of poverty, people with severe mental illness, homelessness, incarceration, and coming from low-income countries, all the stressors of which can be exacerbated by the illness and treatment. And finally, co-infection with HIV can be a significant risk factor for greater depression. For psychiatric side effects from anti-TB meds, most of what we know about psychiatric side effects is based on case reports. So there's very little, if any, studies that have looked at the prevalence of side effects associated with these medications. They're more case reports, meaning a case was observed in this hospital at this time, and these case reports date back to the 50s and all the way through, and the majority of the cases that are reported in the literature have to do with isoniazid. And so in this case, I looked at a review by Pachi et al., and then I did a sort of manual search just last week trying to sort of identify a range of TB medications that have been associated with psychiatric effects. But again, this is just one case here, one case there. This does not speak to the frequency. But isoniazid and cycloserine are the most commonly associated medications linked to TB, to psychiatric reactions. Isoniazid, it's mostly case studies, and the overall observation is that the reaction tends to be more psychotic in nature, tends to be severe, so it's rare but severe. So it's unusual to find the side effects of isoniazid, but when you find it, it tends to be more significant and finds itself in the literature as these case studies. And the other thing to note in terms of isoniazid in the context of mental health is the liver toxicity, which is a significant factor to consider with patients with alcoholism. With cycloserine, there's fewer studies available, mostly because the medication hasn't been used as frequently as used in multi-drug-resistant TB. And but when it is used, the prevalence of psychiatric side effects tends to be very much more common. So a recent systematic review meta-analysis found that 5.7% of individuals receiving cycloserine had some sort of psychiatric side effects. Other studies, for example, one that I was involved in Peru, found new onset of depression, anxiety, psychosis to be 13, 12, and 12% respectively. Other reviews of the literature of case studies found frequencies between 10 and 50%. So it's less common in terms of its use, the medication, but the frequency of side effects is more common and more varied in presentation. Finally, the physiological reaction to the disease, there's some suspicion that inflammatory processes involved with TB may be related to mental health reactions, or vice versa, that inflammation related to, say, depression, for example, may be a risk factor for activating TB. TB and its treatment may lead to exacerbation. The stressor may exacerbate underlying mental health issues, and comorbidity may be as a result of shared risk factors such as substance use and low socioeconomic status, which are also have higher risk for psychiatric conditions. So some of the main challenges in addressing TB and mental health currently are that the problems tend to be under and misdiagnosed. This is for a number of reasons. One, some of the symptoms are overlapping, particularly with depression, for example, anhedonia or lack of pleasure or lower appetite or fatigue. A lot of the symptoms mimic depression and therefore can be confused with depression. There's also a lot of misconception, which is what I was touching on before, and we'll talk about more, misconceptions about situational distress before versus clinical illness and the tendency to conflate poverty and illness with depression. So there's often a misconception that you have a person with TB who's depressed, and a lot of clinicians will say, of course they're depressed, they're poor, they're sick, and there's a lack of recognition of the distinction between depression and sort of sadness as a normative, reactive response versus when it becomes a more clinically entrenched issue that requires a different type of intervention. Screening and identification is not integrated into standard protocols, which is another challenge, and there's often a low priority for mental health services and limited services available, so this can lead to a reluctance to identify the mental health problems, because if there's nothing you can do about it, then if there's no services available, it's hard to rationalize the identification. And finally, there's a limited evidence base for best practices, which is one thing that is desperately needed in the field, and that the working group, the TB Mental Health Working Group that Adam and I co-founded with the International Union Against TB and Lung Disease, that's one of our main objectives, is to find ways to build an evidence base, to identify practices that work, and to disseminate those practices to lots of different settings. So in terms of how to respond to mental health issues in the context of TB, there's sort of three general areas. First is assessment and screening, so the identification of whether or not there is a clinical disorder present, what is it, and And once you know that, then you can think about what types of intervention would be appropriate. So for more of a situational distress, normative reaction to TB being a very difficult life event, and the fact that it tends to happen with people who have lots of other psychosocial stressors and difficulties, is the treatment to help them complete therapy. Should it be more supportive, problem solving, harm reduction, or do they require more clinical intervention, such as individual group therapy or psychopharmacology, how can we think about health and mental health systems integration? So I'm going to go through each of those three. To start, so screening for mental disorders. The thing with mental disorders that's different than other medical conditions is that it's not observable. There's no blood test that can tell you that a person has depression or schizophrenia. We have to rely on clinical assessments that are often generally done by mental health specialists, and that's often not possible in primary care settings or low resource settings. And so what we've come to use oftentimes is what are called screening instruments. And these screening instruments are brief questionnaires. They're often self-assessment, and they're not diagnostic. They're not intended to find cases of a clinical disorder, but they're designed to flag potential cases. So a lot of these scales are maybe 2 to 20 questions. It's not too long. They're either yes, no, or more frequently Likert scale, meaning how many times in the past 2 weeks have you felt this? Like none of the time, some of the time, most of the time, all the time. Then usually the responses are scored to make a total score, and then they use a validation study to determine what the cutoff point should be to determine a case versus non-case. And I'm going to explain that a little bit more. But the point being that these tools are meant to be, they're tools. They're not diagnostic. They're intended to be sort of triage tools so that you can identify and flag cases that require further assessment. So I'm going to go through two very common tools used in the U.S. One is for depression. The other one is about substance use. For depression, there's these two scales called the PHQ-2 and PHQ-9, the Patient Health Questionnaire 2 and 9. 2 is the first two items that are highlighted in red, and those are intended to be just a very, very short screener. And what's often done in primary care settings, for example, in Bellevue Hospital where I work, every single primary care patient who comes in has to respond to these two questions as part of their general check-in. And if they respond positively to either one of those questions, then they're asked to answer all 9 questions. And then their score on those 9 is a determinant of whether or not the primary care doctor is alerted to whether or not they need to ask more questions to this individual. So if you look at the bottom in terms of sensitivity, so PHQ, sensitivity and specificity. Sensitivity is the ability of the screen to identify true cases, and specificity is the ability to rule out non-cases. So in terms of the PHQ-2, it has a fairly effective rate of identification. It can, with a cutoff of 2 or more, it can identify probable cases at 86% and rule out most non-cases. When you go to the PHQ-9, there's more questions, and you have an even higher, sensitivity is 74%, but even higher specificity in ruling out non-cases. And importantly, the PHQ-9 also includes the last question, which is about suicidality, which is, as a screening question, would always trigger a referral. A common example of an instrument for substance use is the Audit-C, which involves 3 questions. How often do you have a drink containing alcohol? How many drinks do you have? on a typical day? How often do you have 6 or more? And based on these 3 questions, there's a slight difference between men and women in terms of reporting that affects the way in which you interpret the scores. But for men, a cutoff of 4 has a sensitivity of 86%, specificity 78%. For women, it has a higher sensitivity but a very low specificity, which has to do with underreporting by women. But this is another example of a 3-item scale that can be used as a screening instrument, as a way to flag potential, to identify cases in which further questions should be asked to determine whether or not there's a clinical disorder. And in terms of treatments, there are various types of treatments. There's pharmacological, psychotherapeutic, and supportive, as I mentioned before. Adam's going to talk a little bit about this intervention with regards to substance abuse.
So the reason for bringing this up in this conversation is the applicability of some of these brief intervention models to primary care settings or other non-specialty settings. And this is part of the theme of suggesting that more attention to mental disorders can have positive benefit on individuals with tuberculosis, but that integrating this attention into practice is doable and can be effective. So the SBIRT, or Screening Brief Intervention Referral to Treatment, is an evidence-based model that's a United States Preventive Services Task Force B recommendation. So it's recommended as part of a primary care preventive service package. It involves screening with the Audit C, the 3-question tool that Annika just mentioned, and then followed up with high scores with a 10-question audit, much like the PHQ-2, followed up by the PHQ-9, and then involves engagement by the primary care provider with the individual in a brief way, supportive way, using principles of motivational interviewing, and with relatively low intensity. A few sessions, perhaps, has actually been shown to decrease binge drinking frequency, decrease average consumption, and reduce hospital admissions. So again, the principle here is that this model of screening, brief intervention, referral, treatment can be incorporated into basic clinical practice in primary care settings, does not involve an overly intensive amount of time, can be relatively easily integrated into standard protocols, and gets good results.
Okay. So other interventions include psychopharmacological treatments. There's several types of psychiatric medications: antipsychotics, antidepressants, mood stabilizers, stimulants, and anxiolytics or anti-anxiety medications. Of note, these using pharmacological treatments has best impact when used in combination with other types of non-pharmacological therapies. And we're not going to get into specifics around these treatments, but rather go in a little bit, talk about what we know in the literature about potential drug interactions and how that might play into treatment. So in terms of isoniazid, to start, isoniazid was actually, interestingly, developed initially as an antidepressant and has antidepressant properties. It has been recognized as a weak MAO inhibitor, and then its effects against tuberculosis were recognized, and so it's been used mostly in the case of is now primary TB drug medication. But The fact that it works on this other mechanism at the same time means that it's theoretically contraindicated for use with SSRIs and tricyclic antidepressants because of the interact, because the type of weak NAO inhibitor might cause serotonin syndrome in patients receiving both of these types of medications. As said, it's theoretical because there have been no cases reported. This was just based on our understanding of underlying mechanisms. This could be a risk. So certain antidepressants may be contraindicated in conjunction with isoniazid, and further examination of this should be pursued before combining treatment. There are also some anti-anxiety medications, benzos, that they interact with isoniazid, and antipsychotic medications. Isoniazid may inhibit metabolism, therefore, may inhibit metabolism of certain antipsychotic medications, such as haloperidol. Therefore, it might be necessary to lower doses of haloperidol during isoniazid treatment. Again, these are very broad observations. There have been very few, if any, clinical trials, so this is all the little we know based on the literature suggests these potential interactions, and these are all areas for future research. With rifampin, although it hasn't been associated with necessarily psychiatric side effects, it does interact with a number of psychotropic medications in an important way, and it's believed to actually lower the effect of these medications, including antidepressants, anti-anxiety medications, antipsychotics, mood stabilizers, sleep disorders, substance addiction, all of these medications, which means that when people are taking these medications and they take rifampin, the enhanced metabolism means that they may require higher doses of these psychotropic drugs to reach the same effect. So it's led to symptoms of withdrawal in that case, and so it might be necessary to higher the doses of these medications that the patient's already on them prior to treatment, if treating with rifampin. Other drug-drug interactions, linezolid, it's a drug newly used for TB. It's more in the experimental phase, looking for use within XDR cases, but it also has weak MAOI properties and therefore may be contraindicated with SSRIs due to risk of serotonin syndrome. Another interesting line of research, which is sort of emerging recently, is that there's some antipsychotic medications that may increase the bacterial activity of some anti-TB drugs or strengthen the effect of certain anti-TB drugs, meaning it might be possible if combining some antipsychotics with the anti-TB drugs may strengthen their effect. There's mixed evidence. There's evidence in both directions from animal models, and there's also some limited evidence that they may independently have their own anti-TB properties. So this is very interesting. Some studies that have happened just in the last few years that shows a lot of promise that has been explored in the context mostly of MDR-TB, and it's certainly just something to earmark for future study. Now Adam's going to talk a little bit about more. We're talking about health and mental health systems integration as an approach to address TB and mental health problems.
Okay, so spoke earlier about a clinical strategy, screening brief intervention, that is applicable in primary care settings to addressing, in that case, substance use disorders. And this, what I'm going to speak about now, is a model that was really developed around managing depression, but is also have evidence for managing other mental illnesses. And again, the theme here is pragmatic and effective methods of integrating attention to behavioral health into primary care. And so the so-called collaborative care model is one that provides a level of assistance and a consultation to primary care providers to allow them to successfully diagnose and manage mental illness. And just to make the point that I made earlier, that to the degree that mental illnesses are identified and treated in the medical system, most of them will not be treated on the specialty side. Most of them will not be treated by psychiatrists, social workers, and psychologists. Most, in fact, will be managed by primary care, need to be managed by primary care practitioners. This is not only a matter of resource limitations, it's also a matter of patient preference. And frankly, for most mild to moderate conditions, they should be managed in primary care. And yet, there are big challenges to doing that. And the collaborative care model acknowledges that primary care physicians and other practitioners need support, need an opportunity to refer when cases are very complicated or severe, but that with a level of support, many of these cases can be managed in primary care settings. And so the key to the collaborative care model is that it is a team-based approach with primary care, specialty care, and of course the patient working together. The use of registries, the systematic and regular follow-up of individuals to assess progress and need for adjustment of treatment, and the use of quantitative monitoring of treatment progress. For example, using the PHQ-9, the score of the PHQ-9 to monitor treatment progress. But the core of the model is that it's a team that involves the primary care provider, a care manager, that is, and listed here are some of the functions of that care manager. And that care manager could be a social worker. It doesn't necessarily have to be a social worker. And you see here that many of the tasks and functions of this care manager are things that could also be applicable to other conditions as well, not just mental health conditions. And then the psychiatric consultant, the specialty consultant, available not only for referral, but for short consultancies, and also in the use of the registry for a systematic review of all patients under treatment on a regular basis. So the principle is that the care manager and the psychiatric consultant provide to the primary care provider the support, technical expertise, and when necessary, a referral destination to allow a comprehensive approach to managing these conditions in the primary care setting. And just to say that this model has been evaluated in a variety of settings and has found to have impressive benefits for a variety of disorders. So again, the challenge of implementing models like this are often end up being issues of billing and fiscal considerations, and of course building those relationships between the primary care provider and the specialty sector. But these are, I believe, issues that can be managed, that can be overcome, and increasingly state health departments and local health departments and behavioral health departments are providing a level of technical support and expertise and technical assistance to help practices develop these sorts of models and implement them properly.
Okay, so finally to wrap up, we're talking about there's a number of research gaps. First of all is gaps and research gaps, operational and research. The first is this raising awareness about the difference between situational and reactive mental distress, and particularly the way in which they may require different type of intervention, which is what I've been talking about today. So, for example, with a more situational, psychosocial situation where someone has lots of stressors and TD is just one of them, they might require extra support to be able to complete treatment. Whereas if someone has an actual clinical disorder, in addition to their TB, it might require an additional clinical intervention in order to really improve the effect of TB treatment. And so understanding the difference between those and how it affects treatment is very important, and that's something that we'll discuss a little bit when we go into the case studies in a minute. Other research gaps involve understanding the prevalence of psychiatric issues. Like I said, there's evidence to suggest that depression, for example, is very high. There's evidence that substance use is very high, particularly in some populations, although that tends to be regionally specific. For example, in Russia, it's extremely high alcoholism rate among TB patients, so it's somewhat more regionally specific. But we need to have a better sense of numbers. But really, we need to, more than that, understand and identify best practices that can be disseminated through vehicles like these types of webinars, both in terms of supportive intervention, psychosocial, in terms of psychotherapeutic, and pharmacological interventions, better understanding of drug interactions, and we need to find ways to use existing data, not just necessarily be prospectively collecting data all the time, but we have lots of data already that can be analyzed to help begin to respond to some of these questions. There's also lots of clinical trials in TB that it might be possible to integrate mental health questions into, which would help increase the evidence base. And finally, we have a need for prospective studies to address some of these challenges. So the International Union Against Tuberculosis and Lung Disease, as we mentioned earlier, Adam and I are leading a TB and mental health working group. Our primary objectives are, and this is at a global level, although there's also interest at a domestic level. Linking researchers in the field, including participants perhaps listening to this webinar, people who have a lot of experience working with mental health issues, who can share their experiences. We want to link clinicians, frontline workers that are encountering these issues and navigating positively and negatively these types of cases. We want to learn from them. So we want to link researchers with these types of clinicians. We want to build an evidence base for best practices and develop guidelines that can be disseminated nationally and internationally. So if anyone listening has interest in joining the working group or learning more about it or participating, you can let either of us know. So that's the end of our formal presentation for now, if anyone has any questions.
So that was great. Thank you both to Annika and Adam for that. We'll open it up to a few questions right now, and then we have a couple of short cases to discuss. So if anybody on the phone has a question or a comment, pound 6 to unmute yourself and go ahead. If there are no questions on the phone, we did have one that was sent in. Maybe, Annika, you could comment. It was a general question about what serotonin syndrome is.
I'm not a psychiatrist, so I'm not actually the best prepared to respond specifically to that question, fortunately.
So I guess I can add. I mean, I've seen it once or twice in my experience. It can be either a mild or severe reaction, usually to a combination of medications that are acting on the same pathway, and patients will present with tremor, agitation, maybe some neuromuscular rigidity, although that may not be the predominant feature. And again, in some patients, at least when you read the textbook, it says it can be very mild. So it's not like they may not present to the emergency room necessarily. They may present, to their outpatient physician, or it can be very severe. They can have a lot of autonomic dysfunction and have high fevers and things like that. So it can be very severe. It can be life-threatening, but it could also be something quite mild, and it can be seen really with a variety of these medications acting together. Okay, can you move that arrow? So another question. Oh, okay. Do you recommend screening all TB clients with mental health screening or a substance abuse screening tool? I think that's probably a question that a lot of the TB control programs have at this point. Should we be screening everybody, since our patients in general probably are at risk?
I mean, my inclination would be to say yes, given that even just these brief screens can be, two questions for depression or 3 for substance use. It's so simple when, the basic standardized intake for a TB patient has all sorts of, nationally protocolized, there's protocols for, for intakes at a national level in the U.S. and other countries, and it seems like it would be relatively simple to integrate, a few of these screening questions in that first page just to flag something at the beginning rather than wait until, months into treatment, someone's not taking their medications and there are all these problems, when you could really potentially sort of identify that up front and be able to incorporate that into the clinical plan for each patient. So in my opinion, I think it would be very wise to incorporate as a routine measure. And I think Adam could speak to it a little bit in terms of the collaborative care model. It uses basically that strategy and uses sort of mandatory screening of, for example, depression of any medical client when they come in, and that's how an integrated model of care can emerge. Adam, if you have any.
Yeah, I mean, I would just echo that and say that the recommendations are that that this sort of screening does occur in primary care settings. The evidence for the ability to screen and detect these disorders and then affect outcomes is there, and that's the basis for the recommendations. In the case of depression screening in particular, if you read the U.S. Preventive Services Task Force recommendation, it talks about recommending depression screening as long as there's good systems for follow-up. And I think that's when considering implementing these types of, as Anya was saying, very simple approaches, it is important to build in the protocols and the procedures for follow-up. But again, those types, whether it's brief intervention in the primary care setting or in the TB setting, or it's referral, or it's some form of collaborative care, the point that we're making is that these are they do require work, they do require thoughtful implementation, but they are doable and they will improve outcomes both for the mental disorders as well as the TB outcomes. So I think it's very compelling to consider doing this routinely in TB settings.
I agree. I think that's right. I think that the screening tools certainly sound like something we can implement. The bigger question, obviously, is what do we do with it afterwards? There's a related question, and I'd love to hear from anybody on the phone as well who may have done this, if anybody has an example of how some of these tools have been incorporated into their TB assessments. If there are any programs that are actively doing this. Or Annika or Adam, if you know of any specific programs either here in the U.S. or outside that are implementing something like this.
Well, the key element of Adam and my sort of core strategy is to try to get programs to do this. But I think that there probably are some that do it, but it's definitely not systematic. And just the fact that TB treatment is so because it's an infectious disease, because there's just so much potential for integrating into standardized protocols that this would be having a few questions here or there. I think would be very simple, and that's sort of what we're advocating to do at the government level.
So I'll just present the cases. These are very abbreviated cases. And I can certainly add more detail, but Annika and Adam, please feel free to jump in at any point. So the first one is a young patient, a young man, 28 years old. He's a migrant worker from Mexico. He emigrated to the U.S. about 4 years prior. His family has all remained in Mexico, and he speaks minimal English. He was hospitalized for typical symptoms of pulmonary TB, cough, and shortness of breath. He was noted to have some liver test abnormalities at admission. And he was subsequently diagnosed with pulmonary TB, and he was then initiated on standard treatment and discharged after that. The sort of bulk of the case really occurred when he was an outpatient. And so there were multiple visits to his home by TB program staff. Both the patient and his roommates were often found intoxicated. And again, the patient appeared to clinic intoxicated. The patient denied having an alcohol problem. He reported that he was consuming just 2 beers a day. But he did have difficulty remaining employed. He had unstable housing. And he was intermittently adherent to his treatment. So I guess, I think we've talked about this a little bit, but one question I would have, again, is, this is sort of doesn't even need screening. It seems fairly obvious what the problem is, but sort of how do we intervene, and how does the TB control program intervene in order to sort of get the best outcome that we possibly can? Is this somebody who should definitely be referred to specific substance abuse counseling services, and really sort of what can we expect, from that approach?
I can speak to some of the system level issues here, and perhaps Annika could talk to some of the more individual level or clinical strategies. But from a system approach, I think that this case illustrates the need for a very close collaboration and connection between tuberculosis clinical providers and other systems operating in communities. And this is standard practice for TB programs. I'm not saying anything new here, but in the case of, for example, substance use disorder treatment, there will be a network of providers available in communities for treating substance use disorders. I would say that though screening is unlikely, screening in a very simple sense may not, the issue may be already well known, but there certainly would be a need for a more in-depth characterization of the substance use problem. There may be some possibility of managing it in the primary care setting, but perhaps it's a level of severity that requires referral. But that needs to be intentional, needs to be thoughtful, and those relationships need to be established ahead of time. And then the other thing just to say is, again, nothing new to folks in the TB control world, but there needs to be a very close relationship not only with the substance use treatment providers, but with social service providers that would be able to address things like unstable housing. And in many cases, there's a very strong interaction between the social factors and the clinical factors.
Annika, do you want to say anything about sort of what sort of, with these sorts of interventions, what the TB program can sort of expect as a best case scenario?
Well, what I would say is that, so like Adam was saying, with substance use disorders, the identification isn't always the hardest part. The hardest part is figuring out what to do. So substance use disorders tend to become very obvious. And in the case with this patient who is intoxicated at each of the different contacts and was clearly interfering with treatment. I guess the piece that is different between substance use disorders versus like depression, for example, as we were talking about earlier, is readiness for change, and whether in a 6 month treatment by referring out to a substance use treatment program assumes that the person actually is ready to enter treatment, which may or may not be the case. It would be helpful, I think, if people within the TB clinic have some skills and training related to motivational interviewing, which is a strategy intended to assess readiness for change. So if the person, is really in complete denial of having any sort of drug use problem, referring them to a treatment is may or may not be effective. But if the person has some insight and recognition that there's a problem and they want treatment, that would be a very useful course. If they have no interest in treatment, then it may be necessary for the patient to be managed at the clinic level, at the TB clinic level, which would mean having skills around harm reduction and sort of working with the patient to be able to find ways to not necessarily stop their drinking, but find ways that that they can continue to prioritize taking the medications in a way that it's not, so the outcome is not stopping drinking, and the outcome is taking the medications at all so that they can finish treatment. And so the management is slightly different. I think it's a combination of linking with referral systems when there's readiness for actual treatment. When there isn't readiness for treatment, it's having a stronger skill base at the clinic level for harm reduction strategies to be able to improve adherence and treatment outcomes regardless of the substance abuse outcome.
Go ahead. There's a question here in the room.
Thanks, Annika and Adam. This is Alfred Lardizabal here in Newark. I think it's great that we're talking about mental issues and behavioral disorders as they relate to tuberculosis and really bringing to the front recognizing that this is fairly prevalent in many of our patients. Going back to this case, I think fear is a very good motivator, and why not just use that? Many jurisdictions have, I'm just trying to be a devil's advocate here, a lot of jurisdictions have legal interventions, and why not just go that way? It's a lot readier rather than seeking out mental health clinics. They seem to respond to fear. Is that the wrong way?
Are you suggesting like incarceration or that type of?
Yes, maybe your opinion with regards to, there are other options that are available to places out there which have to do with sort of being forced to go through certain treatments. A judge will have to order certain things, and in situations such as this where adherence becomes a problem, that may be the first step that a program might use. I guess there's no head-to-head comparison which would have a better outcome, but what would be your opinion on something like that? Is it again a collaborative, multidisciplinary approach, or I think most of the problems we confront is that we don't have people to approach in terms of mental health support.
Yeah, I mean, it's interesting because tuberculosis control and behavioral health actually the systems share some characteristics. One of them is the legal basis for mandatory treatment. But in the behavioral health world, first of all, those are very rare cases. And what I would say is that there's there's a temptation, or there's a potential for resorting to coercive methods of obtaining, of treatment when, and attributing issues of compliance or adherence on individual patient characteristics or patient decision making, when in fact, in many cases, they represent failures of the system to successfully engage and to make treatment acceptable to individuals. And so, not necessarily talking about forced treatment for tuberculosis, but for behavioral, for mental health disorders, the real issue and the real strategy is about creating methods for engaging patients and for making the treatment system welcoming. And for example, substance use disorder treatment, the majority of many individuals in those systems are actually mandated to be in those systems, by courts. It's not the ideal profile of a patient-centered system to have such a high proportion be mandated into care. So I think it's incumbent upon us who are involved in these in care to think about ways of engaging and ways of making treatment appealing, rather than seeking some of these more coercive approaches.
So just to give a little follow-up on this case, and then we'll move on to the next one. This patient was, as you can expect, lost to follow-up after about 2 months of treatment. 4 months later, he presented to a different clinic due to continued symptoms. He was found to be AFB smear positive at that time. He was then admitted to the hospital for 1 month, both for medical reasons as well as for public health reasons. And then upon discharge, unfortunately, the case management team had similar difficulties as before due to his unstable employment. They were ultimately able to find housing, some more stable housing for the patient, which was provided by the American Lung Association and the Department of Health. And the patient did ultimately complete treatment, although 18 months after initiation due to these multiple interruptions, as well as his underlying, presumably alcoholic liver disease. And so while the outcome was positive in the sense that he was completely treated, it certainly took about a year longer than you would normally expect it to. So I think that the housing was certainly one of the main issues in terms of getting him to complete his treatment, in addition to really sort of dedicated case management services and some other incentives as well. And I think, as Annika mentioned, throughout this process, the field staff did notice that he was never completely sort of abstinent from alcohol, but he did cut down significantly once he had the housing. So sort of on similar lines of what we've been discussing. Okay, so our next case, so this is a 50-year-old African-American woman who was diagnosed with HIV in 1998 during her last pregnancy. She has 4 male children, 2 of which are currently incarcerated. She has a remote history of cocaine and alcohol abuse. She has a history of depression, although never treated, and a suicide attempt in 2007. And she has had some interaction with the mental health services, although never continuous. She was diagnosed with extrapulmonary TB, lymph node TB in 2013. This was complicated by drug-induced liver injury as well as other side effects and other medication intolerances, and so she's currently on a TB regimen that will likely take about 18 months of treatment, as well as her antiretrovirals. She's missed, along the course of things, many appointments both with the TB program as well as her infectious disease physician. She has been referred in the past to mental health services, but she never went, at least not in the last couple of years. And currently, she's employed, and her social situation is a bit better than it was before, and she seems to make most of her appointments with the TB practice and says she's doing well. At the same time, she's missed about 4 or 5 months worth of appointments at the infectious disease practice. And so, one of the issues here is clearly this is a very complicated patient. She has a lot on her plate to deal with. And she has both sort of short-term and long-term goals and objectives, and short-term and long-term, mental health issues as well. So what should be our best approach with her, and what's our, best chances of sort of preventing future decline of her mental health?
Well, maybe I could just, again, take it from kind of more of a system perspective. I think that this case illustrates many of the challenges facing the medical system in the United States, where many, especially for individuals with multiple comorbidities and a variety of social stressors and psychosocial challenges. And in this case, it's hard to know exactly what the clinical status is, and obviously that would be an important first step, is to better characterize the clinical need around mental health services. But in the totality of the case, it really points to the need for for team-based care, for collaborative models, for care coordination across multiple disciplines. And I think that increasingly there are models for this kind of work. In the case of mental health and HIV in particular, such care coordination case management models have existed, although not necessarily at the level that's really needed. But with the Affordable Care Act and new models, especially in Medicaid, for care coordination for complex cases, this is exactly the kind of thing that's needed. And I think so. The message ultimately here is that the tuberculosis programs and tuberculosis clinicians should be finding ways to participate and to be actively engaged in these care coordination, case conferencing, multidisciplinary models of patient care. And it's no one practitioner that will have the answer, but it's really that coordinated approach that's necessary. And that includes both the specialty behavioral health providers, especially infectious disease providers, primary care, and of course, with a case manager or care coordinator at the hub of it all.
Yeah, just to add on to that, this seems like Adam said, an ideal sort of case requiring case management, because when I see, for example, a person's missed multiple appointments, there's a history of this and of that, and it's not clear what's going on. They're referred for care, it didn't go. All of this suggests that there's a need for some person, either a social worker or a case manager, someone who's there to say, okay, first of all, what is going on? Is there active depression, suicidality? Is there current, abuse issues going on? What is the active substance use? What are the diagnostic concerns, first of all? Why is she missing appointments? This involves conversation, engagement with the patient, finding out what is it that's interfering, what are the issues, asking, someone needs to be asking more questions. And if she was referred to mental health services and didn't go, why not? Did she not want to? Did she not have transportation? Did she not have a babysitter? I mean, there's clearly, in a case that's so complicated, there's clearly a need for some person to play the role of asking these questions and trying to figure out how to address the very complex needs to support such a patient to complete treatment.
Yeah, I think that would certainly be useful, at least in this patient's case, and I think, part of the issue is that if things are going okay from the TB program's point of view, it doesn't necessarily spark a whole lot of sort of proactive questioning of the patient about their mental health and things like that. So hopefully some of, as this collaborative care model or patient-centered home model comes closer and closer and closer to the ground, to us, to the providers and to the patients, some of that will be, implemented in a more standard format. I think that it would be beneficial for many of our patients. So, I want to take a moment, Adam and Annika, to thank both of you for an excellent presentation and for really developing this topic so nicely. If there are no other questions on the phone, I'm going to turn it back over to Anita, and I also just want to thank our audience as well.
So, thanks, Ami and Annika and Adam. There were several questions that we didn't get to, but those were typed in, and we can try to get answers for you and respond by email. And finally, just again want to thank everybody for their participation and to thank all of our faculty. Thank you, and this concludes the conference.